She walked in, smiling, chatting, holding her coffee. 2 hours later, her heart stopped. Not a single warning on her ECG. You thought she was fine. But potassium was writing her death sentence in silence. She was 38, no history, just a little weakness, some cramps, vitals, stable, ECG, normal. So we ordered routine labs and moved on. That's when the nurse screamed from Bay 3. The results from the lab were finally in, and everyone in the room seemed to hold their breath as the numbers appeared on the screen. Serum potassium came back at a level that immediately raised concern among the medical team. 7.9 millimoles per liter. That's dangerously high, well above the normal range. At this level, potassium can disrupt the heart's electrical system, putting the patient at risk for life-threatening arrhythmias or even sudden cardiac arrest. Yet, when we looked at the ECG, there were no classic warning signs, no peaked T waves, no widened QRS complexes. The heart's rhythm appeared deceptively normal, almost as if nothing was wrong at all. This is the danger of hyperkalemia. It can be a silent killer. Sometimes the textbook changes just don't show up, leaving both patients and clinicians unaware of the looming threat. Especially if the rise in potassium is gradual, the heart may adapt for a while, masking the severity of the problem. But this adaptation has its limits. Sooner or later the heart can no longer compensate, and that's when disaster can strike, often without warning. So, this is medical fact number 7. It's one that surprises even experienced clinicians. Sometimes the tests we trust the most can be misleading. The ECG or electrocardiogram is a powerful tool, but it's not infallible, especially when it comes to certain dangerous conditions. A normal ECG doesn't actually rule out life-threatening hyperkalemia. That's right, even if the heart's electrical activity looks perfectly fine on the monitor, dangerously high potassium levels can still be lurking beneath the surface, undetected. This is especially true in patients with chronic kidney disease or acute renal failure, and those who are taking potassium-sparing medications. These groups are at much higher risk for developing hyperkalemia, and their ECGs can sometimes appear deceptively normal, even as potassium levels climb to dangerous heights. The risk is even greater for people who have missed their dialysis sessions. Without regular dialysis, potassium can build up quickly in the bloodstream, putting patients at risk for sudden severe complications. The symptoms of hyperkalemia might be vague and easy to overlook: muscle cramps, unexplained fatigue, nausea, or just a general sense of feeling unwell. These subtle signs can be the only warning before a life-threatening event occurs. So don't be fooled by a normal ECG. The threat of hyperkalemia is real, and it requires vigilance, especially in high-risk patients. Always consider the bigger clinical picture, not just the numbers on the screen. So, how did we respond when every second counted? The emergency department was a whirlwind of activity, with doctors and nurses working together seamlessly, each person knowing their role in this critical moment. The tension in the room was palpable, as everyone understood the gravity of the situation. We had to act fast, making split-second decisions that could mean the difference between life and death. Our first move was to administer IV calcium gluconate. This medication is crucial because it helps stabilize the cardiac membranes, protecting the heart from the dangerous effects of high potassium. The nurse moved quickly, drawing up the medication and delivering it with practiced precision, while the rest of the team monitored the patient's vital signs closely. Next, we prepared a combination of insulin and glucose. This step is essential to help shift the excess potassium from the bloodstream into the cells, buying us precious time. The process required careful calculation and teamwork, as even a small error could have serious consequences for the patient. We didn't stop there. Albuterol, delivered through a nebulizer, and sodium bicarbonate were also used to further lower the potassium levels. Each intervention was chosen for its unique ability to help stabilize the patient, and every member of the team played a vital role in executing the plan. To remove potassium from the body, we gave Kayexalate, a medication that binds potassium in the gut. But in this case, time was not on our side, so we quickly prepared the patient for urgent dialysis, the most definitive way to clear potassium from the blood. The dialysis machine hummed to life as the nurse connected the patient, everyone holding their breath, hoping for a positive outcome. Slowly, we saw signs of improvement. The patient began to regain consciousness, her eyes fluttering open as the crisis passed. The relief among the medical staff was visible. Smiles, sighs, and a sense of accomplishment filled the room. but it was a close call. She came back, but just barely. We almost lost her. And the most astonishing part, all of this happened because of a normal ECG. It's a powerful reminder that sometimes, even when everything looks fine on the surface, danger can be lurking just beneath. In medicine, we can never let our guard down. Her lab screamed while her ECG whispered, "Hyperkalemia doesn't always look like it does in the textbooks." But you know, medicine isn't just about reading patterns, it's about suspecting the silence.